Hey everyone, and welcome back for another deep dive. We always like to get into the nitty-gritty, and today is no exception.
That's right.
We're going to be talking all about emergency care.
That's right.
So all of you future nurses out there, listen up.
Yes, absolutely crucial.
We've got a nursing education module right here,
Okay.
and we're going to pull out all the most important need-to-know information from it.
Perfect.
And when you're in the ER, every second counts.
Oh, absolutely.
So understanding the order of operations in a crisis is just so key.
It is.
So we're going to be talking about that.
Yeah.
We're going to be talking about the primary survey, the secondary survey.
Mm-hmm.
All those terms you've been learning about, ABCDE sample.
Yes.
And we're even going to talk about some of the trickier cases like crush injuries.
Oh, those are fascinating.
So much more to them than meets the eye.
Yes, a lot of people don't realize how complex those can be.
So let's just jump right in.
Okay, sounds good.
Primary and secondary surveys. These are like the bread and butter of emergency care.
Yes, absolutely. The cornerstones.
Why don't you walk us through the logic behind them? Why are they set up this way?
Okay, so the primary survey, think of that like a really quick triage.
Okay.
You're walking into the situation, you don't know anything about the patient.
Right, just chaos.
Yeah, you got to figure out what's going to kill them first.
Got it.
What needs immediate attention.
Right.
So you use the systematic approach, the primary survey, to quickly assess and address those life threats.
So it's all about prioritization.
Exactly. And then once those immediate threats are taken care of, then you move on to the secondary survey.
Which is a little more in-depth.
Right. It's much more thorough. You're looking for those less obvious injuries, things that might not have been apparent during that initial rush.
So it's like a two-tiered system.
Exactly. A safety net to make sure we're not missing anything.
I love that. Okay, so let's break down the primary survey.
Okay.
ABCDE.
Mm-hmm.
It's a classic acronym for a reason, right?
It is. It helps you remember the order of those critical assessments.
So airway. I feel like that one's pretty self-explanatory.
Right. You're making sure the patient can breathe.
Even if they come in talking to you.
Exactly. You can't assume anything. You need to check for obstructions, make sure the airway is clear.
So like if they're unconscious, their tongue could be blocking the airway?
Exactly. Or there could be blood vomit, foreign objects, anything.
Okay, so we check the airway, make sure it's open.
Right. And if it's not, we use techniques like the head tilt chin lift or the jaw thrust maneuver.
I remember practicing those in SimLab.
Yep. Those are essential skills for any nurse.
Then we move on to B, breathing.
This is all about assessing the quality and effectiveness of their breathing.
So looking at their chest rise and fall, listening for any weird sounds.
Exactly. You're looking for signs of respiratory distress like labored breathing, wheezing, gurgling, any indication that they're struggling to get air in.
And if their breathing isn't adequate.
Then we would intervene with supplemental oxygen, a bag valve mask, or even intubation if necessary.
Okay, so we've got the airway and breathing under control. What's next?
C, circulation.
Okay, so we're talking about their heart, their blood flow.
Exactly. You're checking their pulse, their blood pressure, looking at their skin color and temperature for signs of shock.
Right. Pale, cool, clammy skin. That's a bad sign.
It is, and of course, controlling any major bleeding is crucial at this stage.
So direct pressure, tourniquets, all that jazz.
Yep, all those skills you've been practicing.
And then D, disability.
This is where we're doing a rapid neurological assessment.
So figuring out how alert they are.
Exactly. You're checking their level of consciousness using the AVPU scale.
Alert. Verbal pain, unresponsive.
Yep, and checking their pupils for size equality and reaction to light.
Right. Any abnormalities there could point to a head injury.
Exactly. So we need to catch those early.
Okay, and finally, E, exposure.
This one's a bit more than just taking off their clothes.
Okay.
It's about getting a full visual assessment of their body, looking for any obvious injuries.
But also keeping them warm.
Exactly. Trauma patients are very susceptible to hypothermia, so we need to be mindful of that.
Blankets, warming lights, all that.
Exactly.
So we've stabilized the patient, their bleeding's under control. We've done a quick neuro check.
Yep.
That's the primary survey, right?
Yes, that's the initial rapid assessment to identify and address those immediate life threats.
And then we move on to the secondary survey.
Right, which is, like I said, a much more detailed head-to-toe assessment.
And we use the acronym SAMPLE A to guide us.
Exactly. It stands for signs, symptoms, allergies, medications, past medical history, last meal, and events leading to the injury.
Okay, so we're gathering all the clues to build a complete picture of the patient's condition.
Exactly.
So like a detective.
Exactly. You're trying to piece together what happened, what's going on, and what we need to do to help them.
Okay, so walk us through SAMPLE.
Okay, so S, signs and symptoms. We're asking the patient about what they're experiencing.
So their pain level, any other symptoms.
Exactly. We want to get a detailed account from their perspective.
In A, allergies.
That's pretty straightforward. We need to know if they're allergic to any medications, foods, or anything else that could affect their treatment.
Makes sense. N, M medications.
Here we're getting a complete list of all the medications they're currently taking, both prescription and over-the-counter.
So we can avoid any potential interactions.
Exactly. And then P, past medical history.
So any pre-existing conditions, previous surgeries, chronic illnesses, anything that could be relevant.
Exactly. It helps us understand the full context of their health.
And then L, last meal.
This one might seem strange, but it's important for a couple of reasons.
Okay.
First, if they need surgery, knowing when and what they last ate helps us determine the timing of the procedure.
Right. So we don't want to operate on a full stomach.
Exactly. And second, if they're unconscious or confused, knowing what they ate can help us rule out certain conditions like food poisoning or allergic reactions.
Okay, that makes sense. And finally, E, events leading to the injury.
This is where we try to understand how the injury occurred.
So we asked them what they were doing, how it happened.
Exactly, because the mechanism of injury can tell us a lot about the potential types and severity of injuries they might have.
So if they were in a car accident, we'd be looking for different things than if they fell down the stairs.
Exactly. The mechanism of injury helps guide our assessment and treatment plan.
Okay, so we've got the primary survey, the secondary survey, the sample history.
Yep.
We've got a lot of information now.
We do. We've got a good foundation to start building our treatment plan.
But there's more, right?
Oh, yes, there's always more.
We got to talk about some of the more complex cases like multiple traumas and abdominal injuries and those tricky crush injuries.
Absolutely. Those cases can be really challenging, and they require a deeper understanding of the underlying pathophysiology.
Well, I am ready for the challenge.
Good, because we're about to dive in.
I'm excited. Let's take a quick break, and then we'll be back to tackle those tricky situations.
Sounds good. Okay, so welcome back, everyone. Hope you're ready to get back into it.
Oh, yeah, I'm ready to tackle those tricky situations.
All right, so let's start with the primary survey.
Okay, back to the ABCDEs.
Yeah, but let's unpack them a little bit more this time.
Okay, love unpacking stuff.
All right, so airway, we talked about checking for obstructions, but what does that actually look like?
Yeah, I mean, how do we really know if an airway is compromised?
Well, you got to use all your senses. Look, listen, and feel. Look for any obvious obstructions like blood vomit or foreign objects in the mouth or throat.
Okay, so visual inspection first.
Exactly. Then listen for any abnormal breath, sounds like gurgling or stridor.
Oh, yeah, stridor, that high-pitched wheezing sound.
Right, that can indicate a partial obstruction.
Okay, so look and listen. What about feel?
So you can feel for air movement by placing your hand near the patient's mouth and nose. See if you can feel the air coming out.
Oh, okay, that makes sense. So even if the patient is talking to us, we can't just assume their airway is totally fine.
Right, exactly. They could have a partial obstruction that could worsen quickly, especially if their condition starts to deteriorate.
Okay, so we got to be thorough with that airway assessment.
Absolutely. Now, let's say we've determined that the airway is compromised. What are our options for opening it up?
Well, I remember learning about the head tilt chin lift maneuver.
Right, that's a good one. It's simple and effective. You gently tilt the head back and lift the chin to open up the airway.
But what if we suspect a spinal injury?
Good point. In that case, you would use the jaw thrust maneuver.
Oh, yeah, where you place your fingers behind the angles of the jaw and push it forward.
Exactly, that way you're not putting any pressure on the spine.
Okay, so two different techniques depending on the situation.
Exactly. You always have to be thinking about the patient's specific circumstances.
All right, so we've secured the airway. Let's move on to B, breathing.
Okay, so with breathing, we're assessing both the quality and the effectiveness of their respirations.
So we're looking at their chest rise and fall, listening to their breath sounds.
Exactly. Look for symmetrical chest movement. Is it rising and falling evenly? Are they using accessory muscles like their neck and shoulders to breathe? That could indicate they're really working hard to get air in.
And what about those breath sounds?
Listen carefully. Are they breathing too fast or too slow? Are the breaths shallow or deep? Are there any abnormal sounds like wheezing rails raunchy?
Okay, so a lot to listen for.
Yes, and if you hear anything abnormal or if their breathing just doesn't seem adequate, then we need to provide respiratory support.
So things like supplemental oxygen, a bag valve mask.
Right, and in severe cases, we might need to intubate and ventilate.
Okay, so breathing, taking care of what's next.
C, circulation.
Ah, yes, the heart in all its glory.
Exactly. So we're assessing their cardiovascular status, we're checking their pulse, their blood pressure, their capillary refill time.
And looking at their skin color and temperature.
Absolutely. Pale, cool, and clammy skin can be a sign of shock, so that's a big red flag.
And of course, we need to control any major bleeding.
Yes, that's a top priority. Direct pressure elevation, pressure bandages, tourniquets. We use whatever it takes to stop the bleeding.
All right, C for circulation checked off the list. What's next?
D, disability.
Okay, so this is where we do our rapid neurological assessment.
Exactly. We're checking their level of consciousness, their orientation to person, place, and time.
And using that AVPU scale again.
Yes, alert, verbal pain, unresponsive.
And don't forget those pupils.
Right, we're checking their size, equality, and reaction to light.
Because any abnormalities, it could be a sign of a head injury or some other neurological issue.
Exactly. So we need to be very thorough with our neurological assessment.
Okay. And finally, E, exposure.
This is all about exposing the patient so we can get a complete visual assessment.
So we're taking off their clothes, their jewelry, anything that might be in the way.
Exactly. But remember, we also need to keep them warm.
Right. Hypothermia is a big risk, especially in trauma patients.
Absolutely. So we'll use blankets, warming lights, anything we can to maintain their body temperature.
Okay, so we've completed the ABCDEs of the primary survey. We've stabilized the patient.
Yeah, good job.
Now we move on to the secondary survey
Yeah,
and the sample history.
exactly. And remember, we can start gathering some of that sample information as soon as the patient is stable enough to talk to us.
Okay, so let's dive into sample S signs and symptoms.
So here we're getting a detailed account of what the patient is experiencing, what brought them to the ER, what are their symptoms.
So we're asking them about their pain level, the location of the pain, and any other associated symptoms.
Exactly. We want to get a clear picture of their subjective experience.
Okay, and then A, allergies.
This one's pretty straightforward. We need to know about any allergies to medications, foods, environmental allergens, anything that could affect their care.
Make sense? And M, medications.
We need a complete list of all the medications they're currently taking, both prescription and over-the-counter.
Including herbal supplements, vitamins, anything they're taking regularly.
Exactly, because some medications can interact with each other or with treatments we might need to give.
Okay, so we're being very thorough with that medication history.
Absolutely. Now, P past medical history.
So any
Mm.
pre-existing conditions, previous surgeries, chronic illnesses, anything that might be relevant to their current situation.
Exactly. It helps us understand the full context of their health and guide our treatment decisions.
And then L, last meal.
This might seem like a strange question in an emergency situation, but it's actually very important.
I remember you mentioned that earlier.
Right. So why do we need to know what the patient ate last?
Well, you said it's important for surgery.
Exactly. If they need surgery, knowing when and what they last ate helps us determine the timing of the procedure.
So we can minimize the risk of aspiration.
Right. We don't want them vomiting and inhaling stomach contents during surgery.
Okay, that makes sense. And you also said it can help rule out certain conditions.
Right. If they're unconscious or confused, knowing what they ate can help us figure out if it's something like food poisoning or an allergic reaction.
So it's a simple question, but it can give us a lot of valuable information.
Exactly. And finally, E, events leading to the injury.
This is where we try to understand how the injury happened.
Exactly. We want to know what they were doing, how it happened, were they wearing a seatbelt, did they fall from a height?
So we can get a better understanding of the mechanism of injury.
Right, because the mechanism of injury can give us clues about the types and severity of injuries they might have sustained.
So like a high-speed car accident versus a simple trip and fall.
Exactly. Those are very different mechanisms of injury that will result in different patterns of injury.
Okay, so the sample history gives us a really comprehensive overview of the patient's situation.
It does. It's a crucial part of the secondary survey.
But now we need to talk about some of those more complex cases, those situations that require a bit more specialized knowledge.
You got it. Those are the cases that really challenge our skills and knowledge.
And I'm ready for the challenge. Let's start with multiple traumas.
Okay, so a multiple trauma patient is someone who's sustained multiple injuries, often involving multiple body systems.
So like a victim of a serious car accident or a fall from a significant height.
Exactly. These patients are often critically ill and require immediate life-saving interventions.
So the stakes are even higher in these cases.
They are. The primary survey becomes even more critical because we need to identify and prioritize those life-threatening injuries quickly and efficiently.
So we might have multiple teams working simultaneously.
Absolutely. One team might be managing the airway while another team is controlling bleeding and a third team is stabilizing fractures.
Wow. It sounds chaotic.
It can be, but it's a controlled chaos. Everyone has their role. Everyone knows what they need to do.
And communication is key, right?
Absolutely. Clear and concise communication is essential in these situations. We need to be on the same page to ensure the patient receives the best possible care.
Okay, so multiple traumas are definitely a challenge. Now, what about abdominal injuries?
So abdominal injuries can be tricky because they can be caused by either blunt or penetrating trauma.
Right. Blunt trauma is like getting hit in the stomach, and penetrating trauma is like being stabbed.
Exactly. And each type of trauma presents its own unique challenges.
Okay, so let's start with blunt trauma. What are the main concerns there?
With blunt trauma, you have the force of the impact causing internal damage, often without a visible external wound.
So you might not see much on the outside, but there could be serious damage going on inside.
Exactly, and that internal damage can lead to bleeding organ damage, ruptured blood vessels, all sorts of complications.
That's scary. So how do we assess for blunt abdominal trauma?
Well, obviously, we're going to ask about abdominal pain.
Right. If they got hit in the stomach, they're probably going to be complaining of pain.
Exactly. But we also need to look for other signs like tenderness guarding rigidity, distension, bruising.
Okay, so we're doing a thorough physical exam.
Yes. And we're also paying close attention to their vital signs, their heart rate, blood pressure, respiratory rate. Any significant changes could indicate internal bleeding or other serious problems.
So even if they don't have a visible wound, if they're complaining of abdominal pain and their vital signs are abnormal, we need to be very concerned.
Absolutely. Now let's talk about penetrating abdominal trauma.
Okay, so with penetrating trauma, we have an object piercing the skin and directly damaging internal organs.
Exactly. And this can cause bleeding, infection, organ dysfunction.
So the damage is usually more obvious because you can see the entry wound.
Right. But the extent of the internal damage can be difficult to assess without further testing.
And I imagine infection is a big concern with penetrating trauma.
Absolutely. We have an open wound that provides a pathway for bacteria to enter the body.
So we need to be very careful about cleaning and debriding the wound and giving antibiotics.
Exactly. Infection control is crucial in these cases.
Okay, so whether it's blunt or penetrating abdominal injuries can be very complex.
They can, and they require a thorough understanding of the anatomy and physiology involved.
Now let's move on to those tricky crush injuries.
Ah, yes. Crush injuries. Those can be real head scratchers.
Because they can seem so minor at first.
Exactly. The initial injury might seem fairly localized, but the potential for systemic complications is huge.
And we talked about two major complications, crush syndrome and compartment syndrome.
Right. So let's refresh our memories on those crush syndrome. What is it exactly?
Well, I remember learning that it happens when a large muscle mass is crushed for an extended period of time.
Right. So imagine someone's leg gets trapped under a heavy object.
Okay, and that crushed muscle tissue releases all sorts of harmful substances into the bloodstream.
Exactly. And one of the most dangerous substances released is myoglobin.
Oh yeah, myoglobin, that's the protein found in muscle tissue.
And when it gets into the bloodstream, it can damage the kidneys.
So it can lead to acute kidney injury or even kidney failure.
Exactly. That's why aggressive fluid resuscitation is so important in treating crush syndrome.
So we need to flush out those toxins as quickly as possible.
Exactly. We're trying to protect the kidneys from damage.
Okay, so crush syndrome is all about those toxins. Now, what about compartment syndrome?
So compartment syndrome is all about pressure.
Pressure, how so?
When a muscle is crushed, it can swell up inside its compartment.
Okay, and the compartment is?
It's a tough, inelastic sheath of tissue that surrounds the muscle.
So it's like a closed container.
Exactly. And as the muscle swells, the pressure inside that compartment increases.
And that pressure can compress blood vessels and nerves.
Exactly, cutting off blood flow and potentially leading to tissue death.
Oh, wow. So it's like a pressure cooker, except instead of food, it's your muscles and nerves being cooked.
That's a good analogy, and the consequences can be devastating.
So how do we recognize compartment syndrome?
Well, pain is a key symptom, especially pain that's out of proportion to the injury.
So if they have a relatively minor crush injury, but they're in excruciating pain,
That's a red flag. The affected area might also be swollen, tense, and tender to the touch.
and you might notice decreased sensation or weakness in the limb.
Exactly. Those are all signs that the pressure is building up and compromising blood flow and nerve function.
Okay, so if we see any of those signs, we need to act fast.
Absolutely. The definitive treatment for compartment syndrome is a fasciotomy.
Fasciotomy, what is that?
It's a surgical procedure to cut open the muscle compartment and relieve the pressure.
So it's literally a life-saving procedure in these cases.
It relieves the pressure and allows blood flow to return to the tissues.
Wow. Okay, so crush injuries. They're definitely more than meets the eye.
Those systemic complications can be really serious.
Okay, so we've covered a lot of ground here. Multiple traumas, abdominal injuries, crush injuries,
Those are some of the most challenging cases we face in emergency care.
but they're also the cases that can be the most rewarding.
Absolutely. When you see a patient recover from a life-threatening injury, it's an amazing feeling.
So, well, I think it's time for a quick break. We've covered a lot of information, and I need a moment to process it all.
Okay, sounds good. Let's take a break and then we'll come back and wrap things up.
Okay, so we're back, and my brain is definitely full.
I bet mine too. We've covered a lot of ground.
We have, but you know what they say, practice makes perfect.
Absolutely. The more you learn, the more you practice, the better you'll become at handling these emergency situations.
Okay, so we talked about the primary and secondary surveys.
Mhm.
We talked about the sample history. We talked about multiple traumas, abdominal injuries, crush injuries.
Yep, we hit all the major points.
We did. But is there anything else we should be thinking about as future nurses heading into the ER? Anything we haven't touched on yet?
Well, one thing that's absolutely crucial in the ER is teamwork.
Teamwork. Yeah, we talked about that a little bit when we were discussing multiple trauma patients.
Right, but it's important to emphasize just how vital teamwork is in the ER.
Okay, so why is teamwork so important in emergency care?
Well, for starters, things move fast in the ER. You have to be able to work quickly and efficiently, and that requires a coordinated team effort.
Okay, so everyone needs to be on the same page.
Exactly. Everyone needs to know their role. Everyone needs to be able to communicate effectively, and everyone needs to be working towards the same goal,
You're-
providing the best possible care for the patient.
Okay, so teamwork is about coordination, communication, a shared goal.
Exactly. And it's also about mutual respect and support. You need to be able to trust your team members and rely on them in those high-pressure situations.
Because everyone is stressed, everyone is working hard, and you need to be able to support each other.
Absolutely. Now, when it comes to communication in the ER, there's a really helpful framework called SBR.
SBR. Oh, yeah, I remember learning about that situation, background assessment recommendation.
Exactly. It's a great way to structure your communication with other healthcare providers.
So it helps ensure that everyone is getting the same information.
Right. And it avoids any miscommunication or misunderstandings, which can be really dangerous in the ER.
Okay, so teamwork communication, SBR. What else should we keep in mind?
Documentation.
Ah, yes, documentation, the bane of every nurse's existence.
Well, it can be tedious, but it's incredibly important in the ER.
Okay, so why is documentation so important in emergency care?
Well, for starters, it's a legal requirement. We need to document everything that happens to the patient.
So it's like a record of their care.
Exactly. And it can be used for legal purposes if there are any questions about the care that was provided.
Okay, so legal protection, but there are other reasons too, right?
Yes, documentation is also essential for continuity of care.
Continuity of care, what does that mean?
It means that everyone involved in the patient's care has access to the same information.
So if the patient is transferred to another unit or another hospital?
Exactly. The receiving team can easily see what's been done, what medications have been given, what tests have been ordered.
Okay, so documentation helps ensure that the patient receives consistent and appropriate care.
Exactly. Now, when it comes to documentation in the ER, there are a few key things to keep in mind.
Like what?
Well, first, be timely.
Timely. Okay, so don't wait until the end of your shift to document everything.
Right. Document things as they happen as much as possible.
Okay, that makes sense. What else?
Be specific and objective.
Okay, so instead of saying the patient seems uncomfortable, I would say the patient is grimacing and reports pain level 8 out of 10.
Exactly. Use specific details and avoid vague language or personal opinions.
Okay, so timely, specific, objective. Anything else?
Be accurate.
Okay, so double check everything, make sure all the information is correct.
Exactly. Errors in documentation can have serious consequences.
Right, they could lead to medication errors, treatment delays, all sorts of problems.
Absolutely. So accuracy is paramount.
Okay, so timely, specific, objective, accurate. I think I can remember that.
Good. Those are the key principles of documentation in the ER.
Well, I think we've covered just about everything.
I think so too. We've talked about the primary and secondary surveys, the sample history, multiple traumas, abdominal injuries, crush injuries, teamwork, communication, documentation.
Wow, it's been a whirlwind of information.
It has, but it's all essential knowledge for any nurse working in the ER.
Well said, and
Mm.
to all you future nurses out there listening, don't be intimidated by all this information.
It might seem overwhelming at first, but trust me, you'll get it.
Just keep studying, keep practicing, keep asking questions, and you'll be amazed at how much you learn.
Absolutely. And remember, emergency nursing is one of the most challenging and rewarding fields out there.
You get to make a real difference in people's lives. You get to be there for them in their most vulnerable moments.
And you get to use your skills and knowledge to help them heal and recover.
It's an incredible privilege.
It truly is. So embrace the challenge, embrace the learning, and get ready for an amazing adventure.
Couldn't have said it better myself.
Yeah.
Well, that's a wrap on our deep dive into emergency care. Thanks for joining us, and we'll see you next time.
See you later.